Hey everyone! Welcome back to the channel where complex medical cases come to life with clarity and compassion. Today, we're diving into a fascinating and multi-layered case. Meet Mr. Raymond Governor, a 49-year-old man living with HIV who recently faced a cardiac event requiring a coronary stent. We'll unpack his diagnosis, management, and the unique challenges of caring for someone with overlapping HIV and cardiovascular disease, all while highlighting the importance of multidisciplinary care and psychosocial support. Let's get into it.
Good morning. I would like to present Mr. Raymond Governor, a 49-year-old European male living with HIV infection, complicated by recent non-ST elevation, myocardial infarction, NSTEMI, treated with coronary stenting 3 months ago. His comorbidities include hypertension, dyslipidemia, chronic kidney disease stage 3A, and peripheral neuropathy. He also has a background of anxiety and panic attacks, currently stable with psychological support. Mr. Governor was diagnosed with HIV at age 37 following investigation for persistent oral candidiasis and weight loss. His initial CD4 count was 180 cells per microliter with a viral load exceeding 100,000 copies per milliliter. He was commenced on integrase inhibitor-based antiretroviral therapy, ART, achieving viral suppression within 6 months. His current ART regimen includes dolutegravir 50 mg daily and tenofovir alafenamide imtricitabine combination daily, with recent labs showing CD4 count 520 cells per microliter and undetectable viral load. However, his HIV management has been complicated by peripheral neuropathy, likely ART-related, with stavudine exposure in earlier regimens. Mild chronic kidney disease, eGFR approximately 58. Suspected tenofovir-associated. Dyslipidemia exacerbated by ART, occasional insomnia and vivid dreams attributed to dolutegravir. 3 months ago, Mr. Governor presented with central chest pain radiating to the jaw while walking upstairs. ECG showed T-wave inversion in the inferior leads with elevated troponins. Angiography confirmed moderate right coronary artery stenosis, treated with PCI and drug-eluting stent placement. Since his NSTEMI, he has been commenced on dual antiplatelet therapy, aspirin and ticagrelor, atorvastatin, bisoprolol, ramipril, and amlodipine. His current symptoms include mild exertional dyspnea, but no orthopnea or chest discomfort at rest. Hypertension, diagnosed at age 40, currently well controlled. Dyslipidemia, diagnosed 5 years ago, managed with statins. Chronic kidney disease stage 3A, stable eGFR approximately 58, likely ART related. Peripheral neuropathy, lower limb sensory predominant. Anxiety and panic attacks, stable with psychological therapy. Past oral candidiasis, last episode 2 years ago. Past depression, now resolved. Father died of myocardial infarction at age 62. Mother with hypertension, alive and well. No family history of HIV or autoimmune disease. Mr. Governor identifies as gay and lives with his long-term male partner of 15 years in an inner-city apartment. He works as a graphic designer, recently reducing his workload due to fatigue and post-MI recovery. He is a former smoker with a 25-pack-year history, quitting 5 years ago. He drinks 3 to 4 standard alcoholic drinks per week and occasionally uses marijuana. He reports strong support from his partner and is engaged with an HIV-positive peer network. However, he acknowledges ongoing anxiety about his cardiac health and future prognosis. Cardiac, mild exertional dyspnea, no orthopnea or paroxysmal nocturnal dyspnea. Respiratory, no cough or wheeze. GI, no nausea, vomiting, or diarrhea. Neurological, persistent lower limb, paresthesia, stable. Psychiatric, no current depressive symptoms, anxiety well managed. General, stable weight, no fever or night sweats. General, well groomed, no acute distress. Vitals, BP 124 over 74 millimeters of mercury. heart rate 68 beats per minute, temperature 36.7 degrees Celsius, oxygen saturation 97% room air, cardiovascular, dual heart sounds, no murmurs, JVP not elevated, no peripheral edema, respiratory, clear chest, no crackles, abdomen, soft, non-tender, no organomegaly, neurological, reduced vibration and pinprick sensation distally in both feet, peripheral neuropathy, normal tone, power, reflexes, cranial nerves intact, skin, no rashes, Kaposi's sarcoma, or candidiasis, no lymphadenopathy. Mr. Raymond Governor presents with well-controlled HIV infection, complicated by ART-related side effects and drug interactions, alongside a recent NSTEMI with PCI and stenting, and several cardiovascular risk factors including hypertension, dyslipidemia, CKD, stage 3A, and peripheral neuropathy. His psychosocial background adds complexity, particularly regarding anxiety about future cardiac risk, which is currently managed with psychological support. HIV infection, continued dolutegravir and tenofovir, alafenamide/emtricitabine regimen. Monitor renal function and review ART nephrotoxicity risks, CD4 count and viral load monitoring every 6 months. Watch for insomnia and neuropsychiatric side effects from ART2. Ischemic heart disease, recent NSTEMI. Maintain dual antiplatelet therapy, aspirin plus ticagrelor, for at least 12 months. Continue beta blocker, bisoprolol, ACE inhibitor, ramipril, and statin, atorvastatin. Cardiac rehabilitation referral and serial cardiovascular monitoring. Third, hypertension, continue current antihypertensives, bisoprolol, ramipril, amlodipine. BP target 130 over 80 millimeters of mercury, home BP monitoring encouraged. Traumatic dyslipidemia, monitor lipid profile regularly. Be mindful of potential interactions between statins and ART. Chronic kidney disease, stage 3A, monitor EGFR and urinary protein every 3 months. Avoid nephrotoxic agents. Discuss tenofovir nephrotoxicity risks with HIV specialist. Peripheral neuropathy, conservative management, gabapentin or pregabalin if symptoms worsen. Regular foot care, podiatry involvement, anxiety and psychosocial support. Continue psychological counseling. Encourage HIV peer support engagement. Monitor for anxiety or depression relapse. Mr. Governor's case exemplifies the complexities of managing HIV, alongside cardiovascular disease and other chronic comorbidities. His care requires close coordination between the HIV team, cardiologist, GP, and mental health services to ensure optimal outcomes and quality of life.
What is your approach to cardiovascular risk assessment in people living with HIV?
In people living with HIV, I consider both traditional cardiovascular risk factors as well as HIV-specific contributors like chronic inflammation and ART-related metabolic effects. I start by assessing hypertension, dyslipidemia, smoking history, diabetes, and family history of cardiovascular disease. I also recognize that HIV itself is an independent cardiovascular risk factor. Standard tools like Framingham may underestimate risk in this group, so if available, I would use the DAD risk equation, which is specific for HIV populations. Regular monitoring of lipid profile, renal function, and blood pressure is essential.
How does HIV contribute to atherosclerotic cardiovascular disease?
HIV contributes to atherosclerotic cardiovascular disease through chronic immune activation, systemic inflammation, and endothelial dysfunction. Direct viral effects and ART-related lipid abnormalities, particularly from older protease inhibitors, further increase the risk. Additionally, people living with HIV often have higher rates of smoking and other traditional risk factors, compounding their cardiovascular risk.
What is the rationale for statin choice and drug-drug interactions with ART?
When selecting a statin for this patient, I avoid simvastatin and lovastatin due to CYP3A4 metabolism and the high risk of interaction with ART. Instead, I prefer atorvastatin or rosuvastatin because they have a lower interaction profile. With atorvastatin, I would start at a low dose and titrate carefully, monitoring for side effects like myopathy and checking liver function and creatine kinase as part of routine monitoring. I remain vigilant for any pharmacokinetic interactions with ART.
What is the recommended duration of dual antiplatelet therapy and special considerations?
For a recent NSTEMI with stenting, my plan would be to continue dual antiplatelet therapy with aspirin and ticagrelor for at least 12 months. I would assess bleeding risk using the precise-DAPS score and review interactions between ART and antiplatelet agents. In this patient, on an integrase inhibitor regimen, interactions are minimal, but I would remain cautious and monitor adherence and side effects.
How would you monitor for nephrotoxicity with tenofovir-based therapy?
My monitoring for tenofovir nephrotoxicity includes checking serum creatinine and eGFR every 3 months, and monitoring urine protein to creatinine ratio and urinalysis for glycosuria. I would also check phosphate levels if there were concerns about bone health. Since tenofovir alafenamide has a better renal safety profile than disoproxil fumarate, I would confirm that the patient remains on the alafenamide formulation and collaborate closely with the HIV specialist regarding ongoing ART regimen suitability.
How would you manage ART-related dyslipidemia?
To manage dyslipidemia in the context of ART, I focus on lifestyle modification, including diet, exercise, and smoking cessation. Pharmacologically, I use statins like atorvastatin or rosuvastatin, considering the interaction profile. If lipids remain elevated despite statins, I might add fibrates or ezetimibe, again checking for interactions. If dyslipidemia remains refractory, I would also discuss with the HIV team whether ART modification is feasible.
How would you approach the management of peripheral neuropathy and treatment considerations?
For peripheral neuropathy, I would first exclude other causes like B12 deficiency, diabetes, and alcohol use. Conservative management includes foot care and physiotherapy. If pharmacological treatment is required, I would consider gabapentin, pregabalin, or duloxetine, being mindful of sedation and cardiac side effects. I would avoid tricyclic antidepressants such as amitriptyline given the risk of QT prolongation, especially in a patient with cardiovascular disease. My goal is to balance effective symptom control with safety.
What is your approach to chronic pain management in the context of cardiovascular disease and ART?
In managing chronic pain, I would avoid long-term NSAIDs due to cardiovascular and renal risks. Paracetamol would be my first-line agent. If neuropathic pain required further intervention, gabapentinoids like gabapentin or pregabalin would be considered, while monitoring for sedation and balance issues. Tramadol could be considered cautiously, but I would remain alert to potential interactions with antidepressants and the risk of seizures. Throughout, I would ensure careful medication review to avoid ART and cardiovascular drug interactions.
How would you address Mr. Governor's anxiety regarding the risk of another cardiac event?
When discussing cardiac prognosis with Mr. Governor, I would use clear, empathetic communication to explore his concerns about recurrence. I would provide education on recognizing warning signs, the benefits of cardiac rehabilitation, and reinforce the importance of medication adherence. I would also validate his anxiety and emphasize the availability of ongoing psychological support, including referral back to his psychologist if needed.
How would you approach the impact of HIV-related stigma on his health-seeking behaviour?
I would acknowledge the reality of stigma faced by people living with HIV and explore with Mr. Governor how this may have influenced his health-seeking behaviour. I would create a non-judgmental environment, encourage open discussion, and connect him with HIV-positive peer networks and advocacy groups. My goal would be to foster trust and facilitate ongoing engagement with healthcare services.
What lifestyle modifications would you recommend to optimise both his cardiovascular and HIV-related health?
I would recommend continued smoking abstinence, alcohol moderation, and regular physical activity within the limits set by cardiac rehab. Nutritional advice would focus on a heart-healthy, Mediterranean-style diet. I would also encourage good sleep hygiene, stress management strategies such as mindfulness, and ongoing engagement in HIV care to maintain viral suppression.
How would you coordinate care between the HIV specialist, cardiologist and GP?
I would advocate for shared care planning with clear communication between the HIV team, cardiologist and GP. This would involve regular case reviews, medication reconciliation to avoid interactions, and consistent messaging about treatment goals. I would ensure that Mr. Governor remains central in these discussions to promote patient-centered care.
How would you address potential challenges with adherence in the context of complex polypharmacy?
I would approach adherence challenges by exploring barriers such as pill burden, side effects, or cognitive overload. Where possible, I would advocate for regimen simplification, use of fixed dose combinations, or dosing aids like blister packs or pill boxes. I would also assess support from his partner and explore whether pharmacy services could assist with medication management.
How would you counsel him regarding recreational drug use given his HIV status and cardiovascular risk?
I would engage Mr. Governor in a non-judgmental conversation about his marijuana use and screen for other recreational drug use. I would discuss the potential interactions and cardiovascular risks associated with certain substances. My focus would be on harm minimization, education, and, if needed, referral to substance use services.
What considerations would you make regarding his occupational needs following his myocardial infarction?
Given his reduced work capacity post-MI, I would assess his current functional status and explore a graded return-to-work plan in collaboration with occupational health services. I would ensure that fatigue and psychological readiness are addressed and offer ongoing monitoring to facilitate a sustainable and supportive return to employment.
How would you monitor and support his mental health over the long term?
I would maintain regular mental health screening as part of his chronic disease management. I would encourage ongoing engagement with his psychologist and, if needed, involve the GP or psychiatry team. Peer support groups may also play a valuable role in reducing isolation. I would remain alert to early signs of anxiety or depression relapse, ensuring timely intervention.
Thanks for sticking with us through Mr. Governor's journey. A powerful reminder that managing HIV today goes far beyond just viral suppression. With the right team and tailored care, patients like Raymond can thrive, even with complex comorbidities. If you found this case insightful, don't forget to like, subscribe, and hit the bell icon so you never miss a deep dive like this one. Got thoughts or questions? Drop them in the comments. We love hearing from you. This is MedScroll, bringing clinical complexity into focus, one case at a time. Until next time, stay curious, stay compassionate, and keep learning.